Hello, everyone. I'm Dr. Carmen Pugliafito, and today I'd like to welcome back to Retina Synthesis Dr. Raj Maturi of Indianapolis. Raj, welcome back to Retina Synthesis.
Carmen, always glad to be here. Thank you for inviting me again. Happy to talk about anything you'd like.
Well, there was a very interesting article that you published in the Ophthalmologist in November of last year, suggesting the use of ERG as a tool in evaluating the disease progression in diabetic retinopathy. And we'd like to talk about that because I think this is an under-discussed area. Can you discuss, just introduce the topic to us?
Absolutely. Um, Diabetic retinopathy has long been studied structurally, but functional deterioration, we all know, happens before visual acuity drops, or even before morphology captures the full biological risk that's present. What does ERG actually add to that statement? ERG, especially the flicker ERG, especially the timing of the flicker ERG, which is least subject to any sort of artifact. And when you combine that with pupillary metrics, how quickly it responds to bright light compared to low light, may identify higher risk eyes within the exact same DRSS category. So you might have 10 different eyes with DRSS 35. You might say follow up in 6 months. But those patients who have a much worse ERG characteristic, those you need to see sooner because there's a difference in how they do compared to those with very good ERG with the exact same morphology. So this is us finessing how best to treat diabetics at this point, because at this point, any eye going blind with diabetes is a tragedy. Either a lack of care, lack of ability for the patient to make it back. It's a social issue. We need to be able to catch them early. We need to be able to treat them early so all of them can keep vision. That's 2025, and that's what I want my patients to expect.
So how do you use this in practice? Which patients are you studying with ERG and how often?
So I use it in practice. We got it last year just as a tool to see what else we could do with it. And this tool is something that's actually being studied quite widely. Um, Protocol AR and Protocol AS, both DRCR protocols that are coming online this month, they're looking at what happens to diabetes with various biomarkers, visual acuity being the least sensitive of them, and DRSS scores being useful, but I think there's much more to that 50 years from when the DRSS was published, maybe more now. So I'm using this tool to help me decide where I should send patients back, when I should see them back sooner, if I should take a patient who's just started to get early neovascularization on the periphery. Is that a small piece of early peripheral neovascularization I can watch, which is true sometimes, or is that small peripheral neovascularization just the beginning of something horrible? I think a really bad ERG score would make me want to treat that patient much earlier than them getting to high risk characteristics versus those with a completely normal ERG or almost normal ERG. So that's where some distinction can be made in terms of treatment. And it's really good sensitivity and specificity. We know that.
So does this affect your clinical decision making when it comes to anti-VEGF therapy for diabetic retinopathy?
I haven't figured that out yet. It doesn't seem to, it's a biomarker that's telling me that the retina is functionally worse, that the photoreceptors are not responding well. Maybe the bipolar cells are affected too, but it's not telling me when there's adequate VEGF suppression to keep the disease from moving forward. It's not helping me in that area at all. I think we have better markers for that. The OCT is a good marker. Leakage on fluorescein is also a good marker, but I don't think an ERG is helping us in that particular situation.
Can you discuss the study by Davis and Associates that looked at different evaluative tools and compared them?
Absolutely. I think let's see, this is the 2025 ophthalmology science paper. I think it's the strongest of all the papers that are there looking at ERG as early markers. And it's prospective, longitudinal, and multi-site study asking the real questions among eyes with moderate to severe NPDR and no CS DME. So they're just NPDR eyes. Which baseline test best predicts progression of vision-threatening complications over 48 weeks? So in this particular setting, using the red eval DR score, which is a combination of an ERG response plus pupillometry, it was the strongest single predictor among 56 parameters studied. So then you're going, well, if this is the strongest predictor, it's stronger than DRSS score, it's stronger than visual acuity, it's stronger than fluorescein angiogram. Then you're going, wait a second, that's radically different. What do you mean by all that? Well, that's the good part and also the bad part. They use this study to determine how to decide what the actual marking should be. So they've done a few other studies. In the previous study, they were using the DR score of 21 as a cutoff. In this study, they used 26. Obviously, if you change it, then the positive predictive value goes out, relative risk value changes. And at the end, it was on the basis of about 46 patients who had ERGs. We're looking at this in a very cohesive and positive way using red eval, using completely objective visual field testing, where when a machine shines light in different aspects of the retina, looks at pupil response to see if they can see that light or not. And essentially, it's the automated visual field where the patient has to do nothing, just literally look straight at a target. We're using that. We're using fluorescein angiograms. We're obviously using DRSS scores. And then we're looking at non-perfusion index. We're looking at leakage index. We're looking at almost every parameter we can in early diabetics, medial diabetics, severe diabetics to see what predicts outcome. And we're doing that over 6 years in a large multi-center manner in the DRCR. And this is starting just in this month. So I'm excited about Protocol AR and Protocol AS. So coming back to this specific paper, they looked at all of these, but they had different patients who were doing some tests, other patients who were doing other tests. So there were very few who were doing all of them. And that's part of the weakness of not putting all my weight on this one big study that was out there. What exactly is this paper really telling us? That if you have a bad DR red eval score, that you have a 6 times risk of progression compared to others? Yes, in this small population, yes. Why? I think it's because these functional abnormalities are not just an epiphenomena, then actually what's happening with the loss of photoreceptor cells and a significant decrease in function of the bipolar cells. And that's kind of what you're measuring in the flicker response. And both the ERG and the pupillometry is capturing the biological stress that occurs to the retina when you have so much loss of vascularization, so much loss of capillary perfusion. And those things are not always visible when you're taking a fundus photograph. You can only see the hemorrhages that happen as a result of non-perfusion, but sometimes there can be a lot of non-perfusion with very little hemorrhage. And all of these things may exist in the absence of neovascularization. So that's kind of what this ended up showing. This paper does not tell me that I got to use the ERG in clinic on all our patients. And also, it doesn't tell me that the ERG predicts long-term vision better than existing tools. And it's only because it's a very short study, small paper. The whole paper came out of actually a phase 2/3 study for a biological agent. That agent had no effect, but all of the data was available. So they looked at all of the data, those who were treated, those who weren't, put them in one group, and they were able to do the study retrospectively. This wasn't the goal of the study, but turned out to be a useful thing. And the same people who wrote this paper also looked at kind of a previous paper in 2020 and showed that initially that this red eval system using flicker as well as the ERG response was actually really, really helpful. Um, let's see. Maybe the best way to think of this, not just as the paper, but exactly what it's doing, is to look to see exactly what's being done. Um, you put electrodes on the surface of the eye, on the lid. The patient does not have to be in any dark adapted situation. It can happen right in my clinic lane. The patient never leaves the room. I just say ERG. The tech comes in. The whole test takes less than 5 minutes. It's different from any other ERG you have done. It's a handheld device. And the whole thing is beautifully, the software is wonderfully written on it. You put it against the eyeball, and it tells you if all of those things that you have stuck on, the electrode, the pickup, all of them are accurate or not, if there's enough noise, if there's too much noise. It tells you all of that. You adjust it for a minute, you're done. And then it puts in three different gradations of light: a very low light, a medium light, and a more brighter light. It measures one, the functional response, the actual photoreceptor response, the flicker response. It's looking at predominantly cone function. It's looking at one, the fundamental response, which is the sum of everything that's happening. These are multiple flickers going on at different illuminations. So you can see the pupil response, it measures that. It basically does the pupil response when it's fully small at the max brightness, divides that by the area when the pupil was fully dilated. And then that's one index. It does that at three different light points, and also measures the flicker response at three different light points. It even measures the amplitude, but the amplitude is less sensitive, they have found. It's the timing that matters. And it does a Fourier transform to remove all of the extraneous signals that happened from a previous light flicker, not the current one. And you can look at that too. But really, the simplest way to think of it is what's the flicker response, which is in milliseconds, and how quickly does the pupil react, and how much does the pupil react? If you add up all of those things, you come up with a number. The better you are, the smaller number you get. And if you get a higher number, over 21, over 26, depending on which paper, you know that you have too much retinal abnormality. Cataracts don't seem to play as big a role as we would have thought, because you're not looking at the actual wave height. That's affected quite a bit by cataract. You're literally only looking really at the fundamental response, or the milliseconds, the implicit time, and the implicit time isn't affected much by cataract. So that's kind of what you're doing with this. You're looking at how the retinal electrical response happens over time. And it's a really simple test. And then it's done in less than 5 minutes. They get to go home right away. I have done it post dilation because they come to me that way for the most part, unless I've asked for it at the next visit before they see me. And if you do that, you're just getting the flicker response. Obviously, you're not getting the pupil response. And that's been quite useful too.
Mhm. So are you surprised something
Uh,
with the disease,
Surprised at this
with
one.
with the functional severity compared to the fundus appearance?
Sometimes, absolutely. We've all been through the place where we see the patient go, yeah, it doesn't look too bad, get a fluorescein, especially an optos, and you see massive areas of non-perfusion, these flat neovascularization that's hard to see in the periphery.
Well,
And you know, oh my God, that patient needed a PRP 10 minutes ago. Um, you have a similar change here. You might see a patient with just a few tiny dot blood hemorrhages. You do a fluorescein, you see moderate non-perfusion, but then you do this ERG and have this really high index, showing that the implicit time is really delayed, the pupil response is poor. I know that patient's coming back in 2 or 3 months as opposed to 6 months, because normally, what do you do with a 35? You come have them back in a year, 6 to 9 months, 12 months, or I'll often send them back to the referring doctor because they're too mild and my clinic's busy. This is one of those patients I'm not sending back. This is a patient I'm going, hey, come back, see me, because I know you're going to get in trouble sooner than later. The data shows that you're 5.6 times more likely to get in trouble than the next patient here. The relative risk is high. So that's kind of where I make the judgment call with this. It's a quick, easy to use device, and It looks like it's pretty replicated right now in 3 studies. Um, what are the negatives? They're all kind of related to a proprietary platform. This Retinal DR score is by LKC Technology. Um, we don't really have long-term follow-up. The endpoints obviously are a combination of pupil as well as functional retinal response. And then even a year and a half follow-up or so, 2 years sometimes in these papers, it's still not that long. And other than follow-up, like you asked, is there a patient I'm going to treat with PRP earlier because of this? At this point, I can't say that. However, with AR and AP, these are both 6-year studies, kind of
Mhm.
more in line with what diabetics really go through. They go through a lifetime of disease. Knowing what happens to them through a much longer phase of that life cycle will give us much more useful information on what to do earlier. So I'm looking to see if I can just incorporate these changes. It's a great signal, I think, for a retina specialist who's busy, who is concerned about missing those patients. This is a great simple test to do to see if they should come back sooner. Um, I think AR and AS will give us very good data on what to do with them long term. And maybe I can see in like 10 years from now, let's say 5 years from now, going, hey, everybody with NPDR should get an ERG when they come. If they have PDR, then we already know what to do. Most likely we'll do a vitrectomy early on them based on protocol AP, which I suspect that's what it'll show. And for those with earlier disease processes, my suggestion would be, hey, get this. If it shows good response, they don't have a good electrical response, and come back in a year, or go back to the optometrist, or go back to the referring ophthalmologist, general ophthalmologist. But come here if that response is low. I suspect we'll be able to prove that sooner than later.
It's a whole new world.
I know, right? You wouldn't think that a little sticker on the forehead and a 2, 3 minute test would give us so much information, but sometimes quick functional information is far more useful than, a 20-minute fluorescein and a bunch of photos that a patient has to sit through.
You pointed out in your article that the American Academy of Ophthalmology preferred practice pattern for diabetic retinopathy does now include ERG.
Mhm. As a suggested modality. I didn't write those PPPs, but the PPPs can sometimes be forward looking, and that's exactly what this ended up being. I suspect once we get more data, especially with publications that are not sponsored by the company,
Yes.
it's nice to have independent verified data. And once we get that, I think the uptake in the community will be much higher.
And there's a CPT code for this.
Yes, I mean it's just a standard ERG CPT code, which actually, ironically, the multifocal ERG code pays less than a full field ERG code, even if you only do the photopic component, which is what's being done here. So you can do
Mhm.
the whole ERG in less than 3, 4 minutes, and 5 minutes for the whole test is what they advertise at, and that's pretty accurate. So yeah, you can even get paid for it.
Well, Raj, this was a great discussion about an emerging diagnostic arena. And
Thank you, Carmen, as always. You've been fantastic too, and you've done a great job doing this. Thank you.
and we'll stay tuned. Thank
Thank
you.
you.